Afternoon to every one of us. I'm Pam Hines, and I have the privilege of being the endowed chair holder for the Conway Chair in Nursing Research. And as you know, this is the finale of our 7th season, and I could not be happier about the lead conversationalist who will be leading us today. So, as you know, the Conway Chair Conversation is meant to be a lively, engaging exchange, often between clinicians and researchers from the clinical world, the basic science world, and the translation world. We believe that conversation helps us to create more feasible and likely then to be more successful research ventures. So I'd like then to thank every one of you for having been a part of the 7th season. We are amazed. We are already planning next year's season. But I thank every one of you for making this a fun and lively season. May I now take you to an important message in the chat from Eileen Eng, our lead educator for this entire initiative. And that is to invite you to apply for CNE and CME for attending this particular session. May I now invite you into knowing our lead conversationalists. And please recall that our lead conversationalists will take us into a topic that might even be controversial. They'll share their experiences always. But you too, as a participant, have a role, and that is to contribute to the lively conversation, to be responsive in sharing your views, your doubts, your challenges. So please participate fully. And now to tell you a little bit about our lead conversationalists, I'd like to start with one, and that's Dr. Deb Rieger. And Dr. Rieger has actually 2 doctoral degrees, an MD and a PhD, and I'd like to tell you a little bit about how she came to accomplish both. She actually did her residency here in pediatrics 2013, and she then did a fellowship at the NIH in medical genetics. She began with her PhD studies, and this was at Wake Forest, and she very early on showed her profound interest in medical genetics. From there, she completed her MD education training at the University of Utah, and again, showed her strong interest in medical genetics. I would like to point out she is well boarded in pediatrics and also medical genetics, clinical genetics. And she is our director here within the Division of Genetics and Metabolism of Education. And she is also our PI for the Rare Disease Scholars Program. And I must say, she is known well for her wonderful mentoring of others. I'd like to also then introduce you to Dr. Kim Chapman, and she too is an MD and a PhD. I'm very impressed by the educational preparation and just due diligence of both of these lead conversationalists. Dr. Chapman completed her genetics training at the Children's Hospital of Philadelphia, and then she joined us in 2010. She did complete her PhD at the University of Nebraska College of Medicine and went on to complete an MD there as well. She too is board certified in medical genetics, but medical genetics and genomics, and also board certified in pediatrics. I'm very excited about all of that background. She is our director of the Mitochondrial Disorders Clinic here at Children's National. And I would share with you that she is well known for her incredible ability to work with families. And our third conversationalist, who will be joining us just a little bit later, is Dr. Marshall Summer. And he is our division chief for genetics and metabolism. And he's also our director of the Rare Disease Institute, an institute that he, along with Dr. Mark Batchar, helped to found here. And that may actually be maybe the one and only, or the first in our nation and perhaps the world. I would share with you that his background for internship, residency, fellowship is very much from Vanderbilt University. He is board certified in medical genetics, biochemical, and also in pediatrics, genetics, and genomics. I've been often so impressed by his good nature, his ability to interact with families during very difficult situations, his skill in responding to questions from the nursing staff about a particular patient, his willingness to come in at night, and I might even say at 3 a.m., to meet with a family with a new rare disease diagnosis. This division that we have these three leaders joining us from sees over 8,000 patients a year with rare diseases. I don't know that they could be more expert. And I should mention that Dr. Sommer has over 60 patents to his name. So I want to welcome these three lead conversationalists. And I'd now like to turn this over to Dr. Chapman and Dr. Regier. Please.
So thank you so much for such a kind introduction for all of us. So Deb, Marshall, and I have had multiple conversations of how to integrate patients into research and how their perspective really matters. And we do rare disease. And so we never have a cohort that is very big. All of our cohorts are incredibly small. And in some cases, our patients are the expert in the disorder, because if there's only 9 people with the disorder, our patients and their families know about as much about the disorder and that really matters to them as any one of us do. And so we thought we'd start out by kind of introducing what is the patient's perspective in terms of research, because everybody has a slightly different approach to research. And because we have to work so closely with our patients in terms of their management, in terms of the therapy, and also in terms of their opportunities to participate in research, we thought we'd talk about this to introduce, and then we'll go on to talk about how parents can help us as researchers, but also how they help inform what we ask. They help inform how the FDA approaches clinical trials. They help inform all of those questions, but also how sometimes working with parents can be more challenging and takes a lot of work. And so at this point, I am gonna turn over.
Yeah, especially as you saw in our title, because what parents think matters. And we've all had the situation where we have approached a family that we think that there would be a great clinical trial, or at least a trial that they might be appropriate for. And then we have kind of a group of individuals who say, I don't want my child used. And it's kind of a no-go. Then we have the next kind of group of individuals who say, I can be convinced to participate. And often it's because of a relationship. And I'll be honest, in rare disease, that gets very tricky, because oftentimes I'm their provider. I'm the one they call when they're scared. I'm the one they call when they're panicked. I'm the one they call when their formula isn't available because of the formula shortage. We're those people, right? We're their backup person. So this is the hardest place, I think, for a lot of us in rare disease, to make sure that we're not convincing people of things they don't want. We don't want them to do research because of the relationship, but that often happens. Then there's another group of people that, okay, like if I share it with them, oh, that's a good idea, and they'll agree to the idea. That sounds great. They're happy to participate. The next group is where we're getting a little bit closer to, I think, the interesting thing about this conversation is they have an idea. And they bring you this idea and say, could we do this? Or how do we do this? Or we had this idea. This often comes in the form of, can we try this medication? Hey, I read something about this has an auto-inflammatory effect, and my child has an inflammatory disease. Can we try this medication? So sometimes this is trial and error, even doing off-label work, to be blunt. That's sometimes how we see this. This can also be kind of the start of a conversation of research work. That moves on to, I guess this is like the penultimate. We have a good idea, or we like what you're doing, and we would like to fund you to do more of it. Again, this can be great, and it can also be a little bit of a slippery slope. There are situations, especially going on in rare diseases right now, where the kind of the negativeness of, can you buy gene therapy? Can you buy first line treatment? If you donate enough money to the nonprofit or to the family group, will your child get to be the first one that gets that research kind of medication, drug, gene therapy, whatever it is. But there's also the kind of the altruistic side where they say, I want to fund this idea or pursue this idea.
Even though I know it won't impact my child, because that's oftentimes the true altruistic person, is I know that this trial is going to take too long. I know this is not going to help me. But you get the flip side, which is, well, you can come up with a therapy if we give you enough money.
Right. We can buy speed. Yes. So there is some level of that. The other piece that I think kind of fits there in the funding side is sometimes they want to fund with emotional support. Maybe it's not always funding money, but often there is this, a family will come and say, we want to support you, or they have a memorial fund for a child that was lost, or they want their child remembered. So maybe that's through a case report. Maybe that is through a research project. Maybe it's for something really small. But I mean, that is a situation where they really are invested because they want a legacy for a child that died or suffered from a rare disease or any disease. And we often see that there's some kind of desire for a legacy. The next one is, I want to plan, do, and write up the evidence. I want to do all of the things. So this is this great thing that we're going to talk about mostly today, but I always love to put it in the context. Our patients, especially in rare disease, are involved across all of these different approaches to research at every level. Because it's rare, there's no such thing as anonymous. There's no such thing as, combined data sets. We get consent on case reports. We get consent on small case reports because there's no such thing as anonymous and rare. So there has to be buy-in. There has to be involvement with the family, both in the study and in their willingness to participate. For example, we had a great situation where it was as simple as a case report. Family's like, no, we don't want our child shared. Then we shut down that case report. We don't even start the process because out of respect to them, I know if I step on their conscience, I can't provide great care for that family because I have burnt that relationship. And that second one where you never want them to be doing something because of the relationship, you want them to be doing something because of what it leads to them and their family. So what are some of the underlying motivation factors? There's a little bit of this starting to come out in the literature, but it's really starting to grow. And I love this thought. Every time I work with a family who says, I don't want my child used, I don't want them experimented on, I realize that they truly and deeply understand the risk that goes along with research. Their risk trumps any benefit. They see the risk as outweighing any benefit. If you look at the alternate side, so this is someone who says research is beneficial, and that is why they put so much work into it. They'll invest in it. And then when we see kind of the ultra, so where we have people coming into wanting to be on a day-to-day basis involved in the research, that's often families where they view research as their hope, whether it's for the child who's there in front of them at that moment, whether it's hope for a future for other children with the same disorder that their child might have passed from. But there's even this, it's not just benefit, it's how they view hope. So when we think about these phases of research involvement, again, researchers' hope is going to push us to the right. And when we look through each of these phases of involvement, we can see that as we move forward through each of these steps, we get more and more hope associated with inclusion in research. So I guess my conundrum in this is whenever a family wants to be involved in research, we always have to be very conscious of this is can be one of their mechanisms of hope building. And we have to remember that if we're also their care provider, we have to give appropriate hope levels. So you never want to discourage a family from research, but we have to balance that with the reality of the situation. So one thing we do, at least in our division, is, for example, if Kim is working with a family and enrolling them in a study and they're her patient, she doesn't do the enrollment. I go and do it because I want to be told no if they don't want to do it. So we try really hard to have that give and take, because we never want someone to feel like they're being over motivated, but we also want them to have the hope of the research, and we want them to see the benefits of the research. But we also know that there is risk, and it's always hard in a trial. You can never forget that there is risk, and trying to explain that in a meaningful way.
And I think we talk about this on our individual clinical basis, but we also have to think about this as a continuum in which you're talking about like the interaction with family groups, so the family support groups. And so like, for those people who do research in rare disease, very frequently, you're going to get the same families that see the most benefit from the research versus the risk. And those are also the families that try to push the research through the family support groups. And this leads us to the next.
Yeah, so that exactly leads us in, Kim. So this idea of, one of the functions of many family support groups is to move research forward, because so often that hope is based in research. And it can be a little bit, I'm just going to come out and say it can be a little bit stigmatizing for families that don't view research as hope, because they sometimes can have a hard time finding their place in family groups. So it's always this kind of give and take and push and shove of where do you find hope? And actually being really blunt and honest with families that not every family group is going to be great for you. You keep trying them until you find one. And that's what we ignore. There's not one family group for each diagnosis. There's often more than one.
And to be fair, so both Deb and I are medical advisors for different types of family groups. And so, and you definitely get a flavor with those family groups in terms of what their research is, what their questions are. And in a lot of ways, it's kind of the easiest way to find out what's really important to you if you don't do kind of formal things. Because if you are sitting at the family group meeting, you can get the feeling of what the family groups are. And so different family groups have different flavors and comfort with things, but they also have different questions they think are really important.
And I'll be honest, I volunteer with one family group where it depends on which session and which track you do, because they have two sessions happening at the same time. One is the research track and one is the clinical track. And you can clearly tell which families are saying, we just want the shortest, happiest life we can have, and which families are saying, we are waiting for that research, we're waiting for, gene therapy, and you can almost tell. And it's interesting because I tend to be the one that goes and I do lots of quality of life discussions, I do lots of medical management discussions, and then I have a colleague who goes and she does all of the, like, what's going on with gene therapy and what's going on with that. And I always tell people, you know what, families are invested just differently. And we have to meet our families where they are. The interesting thing I found is that the families in the quality of life group are often the ones who say a little later, you know what, should we do a quality of life study? So when we think about what families think is meaningful, sometimes we think, oh, it has to be a big clinical trial. Oh, it has to be a big, something big. Sometimes it's like here in PCORI, where we say, what's patient-centered? What do they care about? And I think if you look at traditional research, sometimes we think, oh, we need families in the lab doing research and we need them, doing gene therapy studies. Well, what I'm finding with some family groups is they love PCORI work. They love me asking the questions, how do we improve life? How do we find out what's meaningful? How do we do kind of patient or stakeholder in what is important? How do we do patient-centered outcomes?
And I think we're starting to see this come to the fore for other types of research. So a number of the FDA listening sessions are really looking what makes the patient's quality of life better. So can we approve a drug based on quality of life, not necessarily the same markers as we would ordinarily do? And the EU has pushed this even further in that all their grants require a family group to say what they think is the most important outcomes for any research, for any kind of registry for rare disease, all of those kinds of things. So I think we're starting to see this become more and more important, but it's essential to actually address what people really want. Now, does anybody have experiences they want to chime in at this point before we keep going, about like their experiences with families or those kinds of things?
Oh, I'm going to read a comment from Linda. So Linda, you commented, it strikes me that there are different types of hope. Hope for a cure/treatment versus hope for the ability to live a life with better quality of life. Sometimes these may overlap and sometimes they don't. And sometimes they're a research question, and sometimes bringing up research can actually harm that because not every person trusts research. Have you had any success convincing non-believers that research can be helpful? What do you think, Kim?
I think that it depends on what type of research you're really asking for, right? So we can think about research like clinical trials kinds of things. And so some of my non-believers are like, we aren't going to do a drug. But sometimes those non-believers are more comfortable with like a registry or a natural history study because they understand that we don't understand the disease. But on the flip side, some people that are incredibly comfortable with drugs trials do not want to touch a natural history study because they're afraid that their identity is going to be identifiable in the de-identified data.
Yeah.
They're afraid that, that study could get hacked and somebody could figure out that I have this rare disease. So it's odd. You can have different feelings within the same patient towards different components of research.
And Jim, you asked, have you ever had a family switch, like go from not being interested in research to being very interested? I have. And actually the situations where that's happened in my experience, sadly, are when one child has died of a disease and they have a second affected child. In that situation, the family realizes what the real trajectory will look like. There is some level of, they've been through it and they want to go through it a different way the second time. And they realize they're going to go through it and they're going to lose their child, and they want that child to have more of a legacy, and they want to leave behind information for research. That's what I hear from families with a second affected child. Alternately, I worked with one family who chose not to enroll in a study. And when I said, why are you not? And she said, I know we would get into a study, but I'm okay because I lost one child and I'm okay losing the second child. I can deal with that. I want to leave the study for other people that can't deal with that, because I have hope that they can have a good life. And I know that some people only get hope if they're on a study. So I'm leaving that spot for them. So it's a really interesting thing. Like, these are truly conversations you sit down and you have. And every time I think I'm going to predict who's going to say yes and who's going to say no, or why they're going to say yes or no, I'm never right, ever. Never right. So let me go back and read more questions. So Suzanne writes, a brochure developed to address gap at NIH does not have family-focused information about engagement and research. Access to high-resolution print copy of this brochure is available. So great. That's a great thing that we should all go take a peek at. And Pamela, thank you so much. In our research with children with advanced stage cancer, one of the reasons participating in research is altruism, wanting to help others. This is present in at least 25% of study participants in this group. Does this motivation show itself in your studies involving the parents of children with other rare diseases? Absolutely. We don't have the percentages. It's a little bit harder in our situation because of small numbers. And remember, so many rare diseases across nations and across centers. So you're getting, maybe 2 or 3 of the cases that are enrolling these studies that we're talking to here. And we just don't do a good job of crossing all centers to ask these really, I think, meaningful questions.
Can I go back and talk a little bit about people who have changed their minds?
Yeah.
And so I think the other issue comes down to is, a lot of people think of research as just being clinical trials or just being registries, but I think also how the research is presented to the community as a whole, how big the cohort is, has a lot to do with somebody changing their mind. And how they access that particular research also has a little bit to do with how they change their mind. So for example, a web-based access that I can say, okay, there's this thing you can do, web-based questionnaire, might be different than a similar registry study in which someone has to go through me to put medical information in. And so what people's comfort level is very much dependent on how is it presented, how do they present, how do they interpret the risk, and then how is the data entered?
Mm-hmm. Yep.
All right. So do you want to talk about?
And then the other approach is there's actually specific funding going to patient groups now. One example is the Chan-Zuckerberg Initiative, or CZI Rare is One, where they actually are going in and supporting family groups to support their research endeavors. The idea of patient and families as the research entity. This is one large nonprofit doing a lot of funding around this. So, we talk about, parents as researchers and families as researchers. This is being funded and happening. And it's actually really exciting. So this is going to sound bad, but sometimes if you're struggling with funding, there are funding sources specifically to do this type of research that we're going to talk about today. How do we incorporate patients and families either as consultants or as the actual researchers, people doing the data analysis? Pam, you mentioned that I'm the PI for the Rare Disease Scholars Program. So it's a national program where we help people learn how to be rare disease clinical researchers. And we've actually had 2 family groups send a parent to learn about how to do rare disease research. One of them ended up getting one of these large CZI grants. Another one went on and got her PhD and opened her own lab. So these are people that are incredibly committed. And one of them stayed in the field that her child suffered and died from. The other one actually switched fields because for her, she wanted to give back to research, but it was too close to home to do her own child's diagnosis. So she actually switched to an adult disorder that she was interested in. So I always laughed at that, even as we think about the parents' questions, it's just showing them the pathway to understanding and research an entity. So that's kind of the why, in my opinion, as to why we do this. Kim, what's your why we're willing to work with families and do research with them?
Because, we're ultimately taking care of the patient. And, certain things are more important to the families than other things. And if we can't support our patients by not answering their questions of what they think is really important, I think we're not doing a very good job. So I'm going to use an example. So I work with HCU Network America, which is homocystinuria. And homocystinuria is an inborn error of metabolism. And individuals with cystathionine beta synthase, or CBS deficiency, because it's so much easier to say, have a really awful diet. And so, in a really awful diet, as in it's hard to do, it's incredibly tastes awful, and it smells bad. And so people are not the most compliant with the diet. And if you ask the family if there is one thing you could do to make this better, they say it's allow me to eat some real food. Allow me to not have to drink the formula or eat the metabolic foods. And so if we do not do research and we do not look for things that make the diet better, then we will not be serving our patients. And the nice thing is working with the family groups is we can convince the FDA, hopefully, that change in diet is an outcome measure. Because we may not be able to show their homocysteines change. We may not be able to show that their bone density is better. But if we can show that their protein allowance goes up, that is essential to the family for approval. And I think we all have examples of things like that that really mean something to our patients. But if we hadn't asked them what's the most important thing to fix, they may not do it. I mean,
yeah, Deb, I'm wrong on a regular basis when I make assumptions, right?
Right, all the time.
We all are, exactly.
And you know, Deb, you have some examples of things that just make families better, more functional, and a number of your disorders that, like, it would not be as a researcher.
Who knew? Blowing air on them, a fan, increases quality of life. Who knew? Lysosomal storage. Blow a fan on them, improve quality of life. Like crazy things that you never know. Mm-hmm. So the next thing we want to ask ourselves, kind of like that's our why we invest. The next thing we're going to show. Go ahead, Kim.
Oh, sorry.
Oh,
I was
looking. Oh, it's almost there.
I was looking at the questions. Yeah.
And then when. So when's the best way to do this? And this is when we want Marshall to come in. So Marshall, you know, you've been doing this, you know, patient, family centered. How do we involve them in research? How do we use them as researchers? You know, even like Kim has had people as authors. I've created studies together. How have you seen that kind of in the past 30 years evolve over time?
That's a great question, which is not an easy way to say that there's not a simple answer, but here's what I've seen evolve. Particularly in the rare disease field, the families and the parents are closer to the research than any other place. In fact, often are the ones that initiate it. What we're seeing more now is families coming to find researchers to work on their disease. Historically, what we saw is researchers going to find families that then would help them out while working on that disease. So I've actually would say there's been a bit of role reversal. I think a lot of that has to do with the explosion in new disease identification. You know, I think what's the rate? Something like 10 to 11 new molecular genetic changes linked to a clinical phenotype a week. So, you know, you've got a couple of hundred, a year coming along that way. And so the families are taking the initiative now. And then there's been some great examples like John Crowley and others where a really driven and a really focused family member has taken upon themselves, sometimes even the patients, and then has driven building out that research. I would say historically, there was a lot more barrier between the families and the researchers. It was kind of more of an old classic model where the researcher was a little more remote and the families kind of showed up to have the honor of their presence to work with them, sort of thing. Now I'd say it's much more partnership driven. I would say it's much more, I would say there's more of an entrepreneurial feel to it. So particularly with the families driving this, they're looking at how's this going to be affordable? How are we going to get, and they're very goal oriented. It's very much towards, how are we going to treat this or how are we going to do that? Sometimes that will change with time, but those are the biggest changes I've seen.
Well, now I'm going to ask the hard question, because if I ask it, then I don't have to answer it. Nadia, of course, you asked the hard question. Do you feel that there are certain ethnicities that may not enroll in studies? And do you consider that there are specific barriers to that? So Nadia, I think Nadia should have to answer this too with us.
Okay.
Go ahead, Marshall.
So one of the things I ended up on the steering committee for the Black Women's Health Imperative, looking at research. So I co-chair their clinical research arm, and we've actually been looking at this. And the objective data so far we have would suggest, at least in the African American community, participation is maybe 30 to 40% of what you would expect, given the sort of percentages in the general population, things like that. Hispanic population is also low. or lower. Native American is almost non-existent. And of course, there's a lot of interesting issues there. And it's when we talk to families and we talk to patients, one of the biggest barriers has actually been sort of the legalistic structure of our research. And, you know, it's interesting. The IRB was created out of some of those same population background histories, bad histories with research like Tuskegee and others, but has become such a legalistic sort of exculpatory process that the families feel like they're signing their lives away. It's like they're reading the Apple, contract that, is 40 pages long and you can't tell, and your choice is to sign it or not. When it's healthcare, people choose a lot of times not to sign it because they just don't know what they're signing up for. Yeah. Nadia, tag.
So I feel like one of the barriers is like the amount of time and trusting the care provider. So like for me, I would say even in diabetes, it took me a long time to get kids to even get on pumps and Dexcoms. And I mostly work in PG County, which is what we would say I would be less likely of that population to be in studies in general. But I think that there's multiple barriers. One is accessibility. I think that is it easy and feasible for these families to be able to come? Healthcare literacy, you don't have to be educated, but understanding and having family members, right? Do you have a nurse in the family or a doctor or somebody else who can make the language a bit easier for them? And so I think it's like having that support system. And I feel like that's just not there for a lot of families. And I don't think, sometimes I think we say, oh, minorities don't want to be in the studies, but I think our system isn't made to include them in there. But we also have to know what the barriers are and their perception. Like, why do they not want to be on there? Or their cultural? Do they not want family members to know that their child has a condition, for example? And so they don't want to have to do trips to flying halfway across the country all the time and asking somebody to take care of their kids. And so there's a lot of these barriers that I think we're not really doing a good job looking into when we're asking these families to be part of the studies.
And Nadia, sorry, Kim.
I think that also we underestimate the time commitment for a clinical trial. And if you need to work every day, then there's a whole population of individuals who cannot participate in a clinical trial because they can't take all that time off because they're either on hourly wages as opposed to salary. They don't have the vacation, all of those kinds of things. I think that there's a group of folks that are like, I'd love to do that, but I can't because I have to work.
I would throw into one place that there's a lot of success around patient participation is with some of the patient advocacy groups. So the Rare Disease Clinical Research Network at NIH currently has, I believe, 21 large rare disease research consortiums. But by charter, all of them have a patient advocacy group as part of the research team. So there's someone from those organizations, and sometimes it's a parent or family member or the patient. Sometimes it's a professional from the patient advocacy group. But one thing I've noticed is the designs of those studies are often a lot more, let's call it user-friendly. I think Nadia has it exactly right. Kim does too. We tend to over-design our studies because we want to get as much data as possible. We don't always factor in the time and burden commitment to that.
I'm going to read the next comment from Karen Walsh, who agreed that, neurofibromatosis has actually been doing some publishing even where families and patients and groups are involved in the whole process all the way to authorship. And Kim, you have an example here. Tell us a little bit about what it takes to have a family or a patient be an author. Like what kind of, how do you equip them to be at that place? And what does it take to become an author if you're a family member?
So I'm going to explain this a little bit. Approximately 10 years ago, we had a meeting looking for, to provide guidelines for taking care of a particular rare disease called PA. And we gathered these folks together. The folks that have arrows there are actually parents. And they are parents that are incredibly active in two of the major family groups that have individuals with propionic acidemia. And the lucky part is these are parents that are familiar with the disorder, not only because they have children, but because they are also the kind of the heads of those family groups that would take care of these things. But for us to be able to participate, one, the family group had to be interested in the thing. Two, they also had to participate in the discussion. So this is lock these people in a room and have a conversation of what does it look like to best take care of a patient with this particular disorder. And this is the acute management paper. There's actually 5 papers that go along with this. But the parents that participated also had to play a role in not only the discussion, they also had to participate in the editing of the paper, the writing of the paper, and they had some really important perspectives of what it was like to go through this as a parent, because they had all gone through basically metabolic decompensations with their children, and whether there were a few things that would have made that easier when they went through the first time or the second time or the third time. I suspect other people have done this as well, including parents.
Yeah, and Karen mentions that, they were involved in the development of the study, tested some aspects of the feasibility, acceptability, logistics, and comprehension, which were invaluable. But there are also cases where I've been involved where they've done the data analysis, things like that. So we had a statistician who was a family member that wanted to do the stats on a trial. And we're like, well, hey, free stats, why not? So you never know what resources might be available at these family groups that want to jump in and use what they know to move research forward in some really creative ways.
And a number of family groups with NORD actually have registries, actually have the registries and maintain the registries for their rare disease, which is really helpful. I think one of the other things is when you do research, you must have members from the family group buy in on whatever the research is, because Deb and I and Marshall, and I'm sure many of you have had experiences where if the family group doesn't buy in, it basically it sinks the research. And whether it's them not understanding how you have a one-to-one division in terms of drug versus control, so drug versus placebo, or if it's they think that the outcomes are stupid questions, they can totally sink anything that you do. So it's something that you have to bring them in early, and you have to know who the players are in the field.
Mm-hmm. So I don't know, Karen, do you want to take yourself off mute and tell us a little bit about your experience, having a patient as a co-author?
Oh,
how that
sure,
went for you?
Sure. Yeah,
Thanks,
I'd
Karen.
love to. Hi.
Hi.
This is such a great topic, and I feel a lot of excitement, and I think that it feels newer to me, but I think, as you guys have said, some people have been working on this and thinking about this for much longer than our team. But I've been really involved in neurofibromatosis for the past 16 years in the Children's Tumor Foundation, as well as a group called RAINS, which is a group that has been developed about that long ago to look at specific outcomes for clinical trials for all kinds of things, whether it's tumor outcomes, cognitive outcomes, et cetera. But in both of those groups or organizations, I would say it's probably more than 5 years, but there's been a real focus on engaging our patient family community because they're very, very involved. The NF community is a very close one. There's a lot going on in a lot of parent groups through the CTF, et cetera. So within those groups, we have mostly parent members because our patients are children. So, but we have engaged the children in different ways, which has been interesting as well. But so, we have parent members of our committees And, you know, we've gone through a lot of things that you guys were talking about. You know, not every parent is necessarily going to fit a certain role in that way. So we've struggled a little bit with, you know, really trying to be inclusive of parents that are interested and invested and involved and want to be involved, but kind of trying to place them with groups that have best fit what their knowledge base or skill set is too.
Yeah. Yeah.
So that's an important piece, because not everybody's going to write a paper with you, right?
Exactly. They might just get acknowledgement. I have acknowledged lots of families.
Yeah. And so that's a little hard, because some people want to do those things, but they may not really, you kind of know that might not be their strength. So I think it's just about talking about that and creating options for our families. I think they're invaluable. And as a cognitive researcher, this is so important, because we struggle often to, I believe, Marshall's point, where, you know, us neuropsychologists are known for collecting lots and lots of data at all times because we want to know everything about everything. But the truth is, we struggle to enroll patients because we weren't thinking enough about not only the time commitment, et cetera, that it takes for that, but is this important to you? Like, we think it's really important to study ADHD and NF1 or autism and NF1, but do you guys care about that? You know, we think we know what families and patients want, but we don't always. Sometimes it's actually kind of surprising what they're interested in that we weren't even thinking about. So and I'll make this quick because I know you guys have so much to talk about.
It's okay. No, that's the point.
Thank you for letting me share. But so what this one parent worked with us on was actually a survey that went out through the CTF registry. We had 900 plus responses, and we created a survey to find out in cognitive research what is important to you. And we actually had a child version of this survey to try to get at what's important to the kids. You know, is it the friendship issues? Is it the learning problems? Is it the attention issues? All things we know that are common in that population. So this mom and her daughter helped us. You know, we created the survey, but we got her feedback on, like, do these questions make sense? Are they, you know, can you read them? Could your kid understand what we were trying to get at? And we tweaked it based on that. And then, you know, she's been in the mix of the whole all the way around. And, you know, mostly I think with the manuscript, she's very bright, but she wanted to be more in the role of, like, let me read it when you guys put it all together, you know, so that was for her what role she wanted, more in the editing side of things. But it was amazing, frankly. And we learned so much from that survey about what they really want us scientists to be studying. And it wasn't all the things we had on our list. So I'll leave it at that.
So true. Marshall wants to share his screen. So go ahead. We have a few more minutes. So yeah. Take yourself off mute so we can see. There you go. Yeah. And I put another one in the chat for you guys to look at. Yeah.
So one thing you need to be aware of is, given the powers of social media, the speed of the internet and everything else, one of the very popular themes out there right now are patients solving their own diseases. And there's a couple of examples that are very popular. Here's one from NIH, which is relapsing polychondritis, but the NIH researcher doing the work has relapsing polychondritis. And a popular theme now is, we're not going to wait for these scientists to get it done. They don't feel the pressure that we do. We're going to go fix our own daggum selves. And you are going to run across that, particularly with some of the patient-driven research, can be a very positive thing. One thing I always caution investigators who are coming into a field, particularly like rare disease, where the connections between the physicians and the patients are close, you don't want to ever be discouraging about potentials of research, but you've got to be very careful not to be overly encouraging. And a good case example has been gene therapy. The families have been working with physicians working in the field for the years, and, you know, oh, gene therapy, we're working on gene therapy. We're going to have it, you know, just next year. And next year is, you know, always a few years away now for about the last 30, 35 years. So families get expectations built up. And like I said, it's a delicate balance. You don't want to just say, no, we can't do anything. It's going to, you know, there's nothing about this we're going to do. But at the same time, you got to be careful not to be too much the other way, because they will listen to every word you say and they will hold you accountable. So you got to be very careful around that.
I was going to bring up, so Louisa Pyle asked about adults. And so although we are at a pediatric hospital, in rare disease, we see a lot of adults. And the adults with the disorders are actually some of our best information people, because they can say, I have perspective. I've had this for as long as I've been alive. These are the things that I think are really important. And I may not have answered the same, or my parents may not have answered the same thing when I was 6. So, you've got multiple users. You've got the patients, and sometimes as adults, as kids, the caregivers, of which you're working with them in terms of what's important, what's not important. And then I actually have some siblings that are very active within the support groups as well. And because they watch their sibling have the disorder, potentially die of the disorder, and now they're like, I don't want anyone else to go through this, so this is what I'm going to do and these are the things as a sibling I absorb. But knowing what the hat they're wearing when they talk to you is also incredibly important.
So the next question I'm going to read, I'm going to open this up to Kim. I'm going to actually include you, Karen, and Marshall on this one, because Karen, you've done this. Are there any special IRB or journal requirements beyond the normal requirements for inclusion of affected patients and or families in the research itself and authorship of the paper?
So I think the IRB question is complicated because it depends on what kind of research you're doing. It is hard to put a parent on an IRB protocol because of just stuff.
Because they're not employed by Children's National.
Because they're not employed by Children's National, so it becomes complicated.
That's the hardest part, that far and away. Yeah.
In terms of authorship and journals, so it depends on the journal. Journals for a lot of times aren't set up for people who don't belong to an academic institution. So sometimes there's like emails you have to make with the journal editors and those things to figure out how to actually list their academic,
their affiliation. I've seen a lot of the affiliations go to the parent group though. Like they can be affiliated with the parent group and that's their affiliation line. I've seen that.
Yeah, that's often what we get. But sometimes the journals don't have that as a choice. And so then you have to kind of create a new option. But that's usually what we do. And different journals have different rules about how to incorporate those folks in. But if you're doing good publishing, if they participate in design of the study, they participate in writing, and they participate in analysis of data, then by definition, they should probably be an author.
Yeah, I haven't had a lot of trouble with publication issue. In fact, I've actually had a couple of papers where they were saying this is a great perspective to have as part of the paper. And as long as you can document the contribution, which is oftentimes around design and things like that, that's not a problem. Interestingly, depending on where you are at the NIH, it's either strongly encouraged or you've just showed up with a weird two-headed tortoise and they don't quite know what to do with it. FDA actually is now required by statute, and for a lot of the study panels there, you actually have a patient advocate or patient involved in the review process there. So I think I would say it's coming around there. It's just, like Kim said, sometimes the paperwork's a little different.
The EU Metab-EARN and genetics and the genetic stuff all require everything that's a guideline or a registry to have insight from a patient support group. And that's the way that the language reads. How that patient support group or patient advocate is defined kind of depends on the group that you're working with.
I'm looking through comments. Thank you, Kara. This was a great comment too. And there's a couple of links we put in about some adult examples of people doing their own research. If you have more you want to share, that's great. But I see, Dr. Hines, you took yourself off. You're back on the camera, so I'm going to let you jump in here. You deserve last talk, right?
Oh, you're generous about that, Deb. I know we promised you that the June Conway Chair Conversation would be a grand finale. And indeed, it has been. I'm reading the chats. I'm getting some individual messages. We are all thrilled. This conversation is so representative of our best intentions here at Children's National. And I'm really proud of the content and very proud of the lead conversationalists. And I have to tell you, I have really a lot of praise for our participants who indeed lived up to their role expectation of being lively participants. I want to really thank our 3 lead conversationalists. You make me really proud of how you think, how you address your values, and how you live them. I thank each of you. I think we can do more in our own respective research programs, and we intend to do more based on your conversation with the Conway Chair Conversation and parent involvement. So thank you for helping to lead us into a next step. For us, I am very appreciative. And I would like to remind everyone that you are fully eligible